Hello, I am Dr. Vijaya Bhaskar Nori. I'm a cardiac radiologist. Today, I would be bringing you my experience on CT myocardial perfusion, which is one of the latest tools in the armamentarium of CT coronary angiography. We have to understand that the imaging of coronary artery disease is moving beyond the lumen. The new era of functional cardiac CT has started. The imaging of ischemia is now playing a paramount role. Until now, we were doing mainly anatomical imaging, like quantifying stenosis. But now we can do physiological imaging, that is known as functional cardiac CT. And let me share you some of my experiences and also the cases that we have done in the recent past about the CT myocardial perfusion in coronary artery disease. So the evolving landscape can be labeled as from lumen to liters or from pipes to plants. That means we are looking beyond the lumen now into the physiology of the blood flow to the myocardium, that is in milliliters. Then we are looking from pipes to plants. We are now going beyond the pipes, that is lumen and the luminal narrowing, to the plants, that is the tissue, that is the myocardium. Tissue level imaging is being done with functional cardiac CT, and that is exactly what the myocardial perfusion is about. We are moving from anatomical stenosis to functional significance of the stenosis. So let us look at the pathophysiology of coronary ischemia and the autoregulation. Now, this slide tells us about the macro circulation and micro circulation. So the epicardial arteries here are the large arteries which form the macro circulation, which carry the blood to the myocardium. Now, the micro circulation is the small arteries, arterioles, and capillaries. And this is where the autoregulation takes place. The main arteries or the epicardial arteries can get blocked and produce ischemia. Similarly, the small arterioles and capillaries can also get blocked, and that is responsible for what is known as coronary microvascular dysfunction. So, till now, we have been looking at the epicardial arteries and then giving the diagnosis of stenosis or no stenosis. Even CT-FFR will tell us about the epicardial arteries and the pressure drop from aorta to the epicardial arteries. Whereas the CT myocardial perfusion at a tissue level will tell us about what is the status of the arterioles, capillaries, and the microvascular dysfunction. That is what is the importance of CT myocardial perfusion. Now, just to make you understand what is meant by compensatory autoregulation, during rest, even if there is 85 to 90% of epicardial artery stenosis, because of coronary compensatory autoregulation, the coronary blood flow is maintained. That is maintained because of various mechanisms which are myogenic and local metabolic, which cause dilatation of the arterioles and capillaries so that the coronary blood flow is maintained even if there is 85 to 90% stenosis at rest. But under stress or under hyperemia, when you give adenosine or when you ask the patient to do a treadmill and do the study, a stenosis of more than 45% initiates a decrease in the coronary flow, and that is what is known as a ischemic cascade. So, under maximum hyperemia or under maximum stress, when you try to increase the demand of oxygen to the myocardium, then even at more than 45% stenosis, the autoregulation fails and the myocardial blood flow is reduced because the arterioles cannot dilate anymore. They have dilated to the maximum. So that is when the ischemic cascade develops. And that ischemia is what we are going to pick up in any of these modalities, like a quantitative perfusion parameters, like you do CMR or you do PET or you do SPECT or you do CT myocardial perfusion. All of these modalities where we do dynamic stress-induced myocardial perfusion, those modalities are going to pick up this reduction in the myocardial blood flow in hyperemia or when the maximum hyperemic stress is given, and a epicardial stenosis more than 45% will show up as a reduced myocardial blood flow And those segments are the ones which needs treatment in the form of revascularization. That is the whole pathophysiology of the myocardial perfusion studies. Now we should understand that there is always an anatomic physiological mismatch. Ischemia does not equal diameter. Nearly 50% of intermediate coronal lesions identified anatomically obstructive do not exhibit hemodynamically significant ischemia. Guiding revascularization procedures purely on anatomical criteria leads to suboptimal patient selection and failure to improve ischemic outcomes. What is the clinical rationale for CT myocardial imaging, myocardial perfusion imaging? The visual specificity on anatomical CCTA drops to 50% when evaluating intermediate stenosis, that is 50-70% stenosis, or in highly calcified vessels. That means you are only 50% accurate when you diagnose stenosis. At 50 to 70%, that means intermediate stenosis, or when heavily calcified vessels, your stenosis quantification is only 50% accurate. Now, the functional myocardial perfusion studies will integrate the coronary anatomy, the plaque composition, downstream hemodynamic ischemia, all of them in a single visit when you do the CT myocardial perfusion. And this becomes a one-stop shop paradigm. That means in a single CT study, you can do a calcium scoring, you can do plaque composition, you can do coronary anatomy, you can do quantification of stenosis, you can do FFR, and obviously the CT perfusion at a tissue level, so that you're going to tell in these situations like 50-70% stenosis or heavily calcified vessels that this stenosis is hemodynamically significant or not significant. That means it needs a stent or no, or a bypass or no. So that is the importance of myocardial perfusion. Now, the perfusion abnormalities are among the earliest manifestations of an evolving ischemic event, and they precede the wall motion abnormalities, ECG changes, and clinical symptoms. Now, let us look at the types of CT perfusion. There are two types of CT perfusion. One is a static perfusion, other is a dynamic perfusion. In both of them, adenosine is given. That means the stressor, the pharmacological stressor is given to increase the blood flow hyperemia, overall hyperemia and coronary hyperemia. Both of them are done. We do static and dynamic perfusion. Now, in static perfusion, after giving adenosine, it is a single acquisition, single breath-hold acquisition, just like a CT angiogram or a coronary angiogram. And then you get reformatted images. And that is a qualitative study. You only look at the perfusion defects on the CT scan images, in the reformatted images. And radiation is definitely low. Whereas in a dynamic perfusion, after giving adenosine, you acquire multiple data sets, multiple sequences, about 15 to 20 after giving adenosine. That means after giving the adenosine, when the peak hyperemic stress is achieved, you acquire multiple acquisitions, 15 to 20. These are non-breath-hold sequences, shallow breath-hold sequences. These are quantitative evaluation. They do quantitative evaluation. They give you absolute myocardial blood flow values or numbers. And you need a dedicated software for post-processing. You need dedicated AI-based algorithms for post-processing. And obviously, because you do a dynamic study, you have multiple acquisitions, radiation is high. Now, in this dynamic study, we do both stress and rest perfusion, and both of these studies are multiple acquisitions. So radiation is obviously high. So that is why you need a special hardware, special software to post-process these multiple data. You need AI-based algorithms to give you the accurate numbers of the myocardial blood flow. So this is an objective evaluation or quantitative evaluation, dynamic perfusion, and that is the mainstay of CT myocardial perfusion. Now, when you do the stress myocardial perfusion, you give adenosine, and you should make sure by using all these parameters that the patient does not have these medical conditions, so that adenosine should not be given. So severe asthma, don't give adenosine. AV blocks, complete heart block, third degree AV block, don't give adenosine. Hypotension, less than 100 millimeter mercury systolic blood pressure, don't give adenosine. Heart rate, less than 50, do not give adenosine. So similarly, patient preparation, ask the patient to stop caffeine for 24 hours prior, fasting for 3 to 4 hours. Use a separate IV line for contrast and for adenosine. Don't give them in the both by using a three-way, don't give both of them, but give separate IV line, use separate IV line. And just like a CMR stress perfusion, give 140 micrograms per kg per minute, calculate the dosage, give the dosage from a separate IV line, and then before starting the procedure, check for the blood pressure, check for the heart rate, check for proper IV line management, and then start the procedure. Now, the principle of dynamic CT perfusion is you first prepare the patient, check the heart rate, check the blood pressure, calculate the dosage of the adenosine, 140 micrograms per kg per minute, give it for 3 minutes. So on CT scan, because the study is done fast, the acquisitions are finished in 20 seconds or 15 seconds. You can finish off the study adenosine in 3 minutes. Then as you achieve the adequate stress with adenosine in 3 minutes, start the procedure, give contrast, 50 ml of 350 milligram iodine, 5 ml per second, acquire 15 to 18 phases, free breathing sequences in a dynamic stress perfusion. Then this particular data is processed using a dedicated software, and then by using mathematical deconvolution, the basic fundamental is time attenuation curve. That is the amount of iodine in the myocardium, wash in and wash out. So the wash in and wash out curves in the myocardium are estimated in the normal myocardium and then in the abnormal myocardium. And whenever there is significant epicardial stenosis, there will be blunted response to the iodine uptake in the myocardium. And that blunted response is calculated by various mathematical calculations and deconvolution algorithms and AI-based software, which is going to give you the myocardial blood flow, absolute myocardial blood flow in normal and abnormal myocardium. And this myocardial blood flow values can be depicted as color-coded perfusion defect diagrams here, or with absolute numbers in ml per 100 ml per minute of myocardium. ml per 100 ml of myocardium per minute. So this is the output that is taken into consideration to give a diagnosis of a myocardial segment ischemic or non-ischemic. Now, whenever you do a dynamic stress perfusion, the first important point is trying to talk to patient, assure them, reassure them about the adenosine complications or adenosine effects. Talk to them, tell them, take them into reassurance. And one important point, what I have understood and what I have learned from my senior colleague, Dr. Kumareshan, is that whenever you do a perfusion, number one, ask the patient to do some exercise. So the exercise, what I ask is the patient is to do limb elevation. Within the 3 minutes, ask him to do the limb elevation, alternatively each limb. This has two effects. One, the peripheral vasodilatation and pooling of blood will be reduced, and the cardiac output, the cardiac output or the blood coming to the heart will be improved. Number one. Number two, the patient will concentration will be more on doing the procedure, doing the limb elevation, and he will try to overcome the somatic complications like flushing and chest pain, chest discomfort. Those are relatively ignored by the patient. So by doing this procedure of limb movement, number one, bradycardia and hypotension in supine position can be averted. Number two, increased blood flow to the heart can be maintained. Number three, the patient more patient reassurance, and patient will try to ignore the somatic complications of the adenosine, and then will give a better compliance. So how do you validate hyperemic stress? How do you validate after giving adenosine? Heart rate increased by 10 to 20 beats per minute. Systolic arterial drop by less than 10 millimeter mercury, or patient symptoms, facial flushing, transient chest warmth, and metallic taste in the mouth. That is when you have achieved the peak hyperemic stress and start giving the contrast and do the multiple 50 to 20 acquisitions. If the patient develops any complications because of the adenosine, stop the infusion immediately. Adenosine has only 10-second half-life. So immediately the the complication, the symptoms will come down. Bradycardia, hypotension, flushing, chest pain, chest discomfort, all of them will come down. Reassure the patient, supportive care, monitor vitals, stop the infusion immediately. That is important. Then aminophylline is one drug which you keep ready with you. Aminophylline, always keep it ready with you. And aminophylline reversal can be done in complicated cases, in difficult cases. And aminophylline comes as this vial. Take a vial. It is 10 ml vial. Each ml contains 25 milligrams. So when the patient develops severe hypotension or bradycardia or severe chest pain or severe symptoms, severe somatic symptoms, as a life-saving procedure, you try to administer 50 to 250 milligrams of aminophylline. That means dilute the 10 ml of aminophylline in 50 ml of saline or 100 ml of saline and slowly infuse over 30-50 seconds about 50 to 250 milligrams of aminophylline. Obviously, most of the times you don't need aminophylline, but in such case, but remember that aminophylline, you get the vial of aminophylline, give 250 to 250 milligrams over 30 to 60 seconds. Usually you don't need. When you stop adenosine, automatically all the complications will automatically get reversed. And what are the indications for aminophylline reversal? Are persistent hypotension, high degree AV block, severe bronchospasm, severe ischemia, signs of poor perfusion, pallor, cold, clammy skin or cyanosis, and patient intolerance to adenosine. Now, there is one more interesting and very accurate modality known as CTFFR. Now, CTFFR is also very useful as a physiological testing to pick up the hemodynamically significant ischemia when it's less than 0.75. Sensitivity is 90%, specificity is about 86%, no stressor agent or additional scans are required. But the problem with CTFFR, what I'll show you in my examples also, is there is 25% scan rejection rate. It is heavily motion sensitive. Garbage in, garbage out. Motion artifacts. You cannot get good CTFFR values. They're false positive values. Similarly, heavily calcified vessels, calcium more than 1000. Actually, heart flow says that any calcium more than 1500, FFR is not a good modality to get the diagnostic values. So, CTFFR is good, but has its limitations in 25% of people. And that is why you need one more physiological testing, that is CT perfusion, to give you accuracy, high degree of accuracy to pick up hemodynamically significant stenosis in the epicardial arteries. Now, what are the indications for CT perfusion? Intermediate stenosis, 40 to 69% stenosis. Myocardial CT perfusion acts as a critical functional gatekeeper, resolving anatomical ambiguity and gives you direct, precise patient care advantage. So 40 to 69% stenosis provides immediate functional clarification by mapping hemodynamic significance stenosis and identifying flow limiting lesions. Severe coronary calcification bypasses spatial blooming artifacts in Agatston score more than 400 to confirm if downstream medical tissue is ischemic. Primary revascularization, that is stents in metallic stents, bypass grafts. Whenever a patient comes to you with signs of ischemia, chest pain, post bypass and post stents, the CT myocardial perfusion is a good modality to pick up a significant stenosis. Then coronary microvascular dysfunction, that is patient stenosis, the epicardial artery stenosis is less than 50% or no stenosis. Patient has chest pain. In such situation, the myocardial perfusion will help us in trying to tell us whether it is myocardial, whether it is a microvascular dysfunction or a significant epicardial stenosis. These are the guidelines by the SCCT in 2021, where intermediate lesions, 50-70% stenosis, requiring proof of ischemia. If you don't have FFR or if FFR is inconclusive, then do myocardial perfusion. In heavily calcified vessels, when FFR has wrong interpretation, then do CT myocardial perfusion. Stent follow-up and bypass follow-up, you can try and do CT myocardial perfusion. Whereas CT myocardial perfusion is not indicated to rule out strategy, that when there's low likelihood of ischemia, then CT myocardial perfusion is not indicated as a rule out test for significant ischemia. The basic requirement for the hardware is you need a 16 centimeter wide detector or a third generation dual source CT scanner. Advanced AA processing tools to quantify myocardial perfusion parameters accurately. You get so much of data in stress and rest that you need the dedicated software, AI-based software, to calculate the perfusion parameters. They show the color-coded picture of the perfusion defect, and then give myocardial blood flow values in rest and at stress. That you need a different, you need a AI-based software. Now, what is the algorithm used? Generally followed. If there is chest pain in unknown CAD, you don't know it's a CAD, just chest pain, do a calcium score first, and after the calcium score, do a coronary CT angiogram. If the coronary CT angiogram stenosis is more than 50%, go and do a CT stress perfusion to look at the hemodynamic significance of the more than 50% stenosis. Now, if the patient has a chest pain in a known CAD, or a previous myocardial infarction, or a previous stent, or a previous bypass, or very high calcium score, that means a patient comes to you with chest pain and high calcium score, already calcium has been done, it is more than 400,000, 2,000, then you do first stress imaging, then followed by rest imaging or a CTA only. So you can do both stress and rest perfusion, or the rest can be done only as a CTA and no need to do rest perfusion. You can reduce the radiation dose, and then you can do a delayed iodine enhancement study, so that you have got a complete picture in front of you regarding ischemia or infarct. Now, why you should do a CT scan perfusion? Now, CT scan perfusion is going to give you the absolute myocardial blood flow values, which are the most accurate objective method of assessing coronary ischemia. And the output of myocardial perfusion is myocardial blood flow values. And those are the ones which are more objective. And those are comparable to SPECT, PET-CT, CMR, and CT-FFR. Now, what are the output parameters of myocardial perfusion? Most important is myocardial blood flow. Then you get myocardial blood volume. Then you get perfused capillary blood volume. Then you get a flow extraction product. But among these, the most important parameters are myocardial blood flow, that is absolute myocardial blood flow, and relative myocardial blood flow, which I'll show you in the examples. How do you read a CT myocardial perfusion data? It is subjective and objective. Subjective is visual perfusion defect, and objective is by looking at the absolute and relative myocardial blood flow values. Now, in a visual scheme, ischemia manifests as an inducible subendocardial low attenuation dark zone seen only in stress and not seen in rest. So when there is a rest, normal perfusion, whereas you see a defect in stress, that means that is ischemia. Whereas an infarction appears as a defect in both stress and rest. Then the subendocardial gradient, a true ischemic deficits consistently begin in the inner subendocardium and advance outwards to epicardium. Now, the quantitative dynamic flow parameters are, you measure the absolute stress myocardial blood flow. If it is less than 90% per 100 ml of myocardium per minute, that means it is definitely ischemic myocardium and it needs revascularization. Look at this example of a 58-year-old male, diabetic, hypertensive, family history of CAD, no chest pain or SOB, and he develops only SOB and chest discomfort on severe exertion. Coronary calcium score is 1791. LAD has 875, LCX 379, RCA 461. And look at the CT angiogram of this person, of this individual. It has been done as a part of myocardial perfusion study. There is severe calcific disease, severe triple vessel disease with extensive calcium. RCA is almost subtotal occlusion. Now, when we do the perfusion, here you see this is a stress perfusion, this is rest perfusion. In the basal to mid anterior wall, you see perfusion defect, that is the purple areas are perfusion defects. In the stress perfusion or rest perfusion, red is normal. That means 150 ml, minimum 150 ml of myocardial blood flow, and slowly the grading from red to purple to blue is low blood flow. So here you can see that in rest perfusion, the anterior wall, there's a purple defect. In stress perfusion, there's a purple defect. That is an infarct. Now, when you come to the septum, you can see that in rest, it is green. That is still the blood flow is above 100 ml per myocardium. Whereas In stress, there is a blue defect, blue to purple defect here in the septum. That means there is a stress perfusion defect which is not seen in rest. That is ischemia. Whereas a defect is seen at rest and at stress. That is infarct. Similarly, this is a 72-year-old male, hypertensive, asymptomatic, TMT mild positive. Calcium score is 900. Proximality, there's a tight lesion. You can see that in stress-only myocardial perfusion study, in the anterior wall, you can see a blue defect in the stress-only study. Similarly, in the anterior wall, in a two-chamber view, anterior wall, anterior wall. So this defect is an ischemic defect, which can sometimes be mistaken for a beam hardening artifact. That is why only the perfusion defects on the color-coded picture are not of very high diagnostic value. You have to corroborate them with a absolute myocardial blood flow values also. So visual perfusion defects are prone to artifacts. Now, what are the absolute parameters to say that the particular defect is significant ischemia? An absolute myocardial blood flow value of less than 92 ml per 100 ml per minute of the myocardial segment is very, very suggestive of significant hemodynamic ischemia. Similarly, in the rest myocardial blood flow, normal healthy myocardium has 80 to 120 ml per 100 ml per minute. If any rest myocardial blood flow is less than 80, then there is definitely reduced rest myocardial blood flow, which is commonly seen in a coronary microvascular dysfunction. Similarly, you can calculate the coronary flow reserve by taking the ratio between the stress and rest myocardial blood flow in the same segment. And normally, the threshold is more than 0.2 is normal. Now, a myocardial blood flow, also known as a relative myocardial blood flow, is you take the target segment myocardial blood flow versus presumed normal remote myocardial blood flow at peak stress, and normal is more than 0.75. If it is less than 0.75, that means it is definitely significant stenosis. And this relative myocardial blood flow ratio is highly accurate for identifying focal epicardial stenosis and sometimes evaluated on a stress-only protocol. Now, this can underestimate ischemia in case of balanced triple vessel disease, where a truly normal remote zone does not exist. So that is why absolute myocardial blood flow values are today, as on today, the mainstay in trying to diagnose hemodynamic significant stenosis. And any absolute myocardial blood flow at stress less than 100 ml per 100 ml per minute is considered to be significant ischemia. Now, there are various, there's a meta-analysis, a pooled meta-analysis, which shows from 23 studies that normal myocardial blood flow at stress, to say it's normal myocardium, it should be more than 139 ml. To say it is ischemia, it is 92 ml. In stress, mind you, in stress, normal is more than 139 and abnormal is less than 32. To say it is ischemia. Now, let us look at some studies at Vista Imaging Center, where I practice. Till now, we have done about 25 stress myocardial perfusion studies. I'll show you some examples. And this is done on a UCT 960 640 slice premium CT scanner using a 16 centimeter Z-axis coverage, 0.25 centimeter rotation, axial studies, and advanced AA server to calculate CTFFR and myocardial blood flow values. Case 1, 61-year-old male, chronic diabetic, well-controlled, physically active, asymptomatic, screening CTA done, calcium score is 1700 Agatson units. We have done a CT angiogram as a part of the stress and rest myocardial perfusion. Heart rate was 82 beats per minute. You can see severe calcific triple vessel disease. Severe calcific triple vessel disease. LAD, LCX and RCA. CTFFR was done, and which shows that in LAD, it is 0.78. In LAD, it is 0.78. That is borderline perfusion, borderline ischemia. Then RCA, it is 0.62. And in circumflex, it is 0.75. That means to say that RCA, there is severe disease, definite ischemia. LAD and LCX, there is borderline ischemia because 0.75 and 0.78. Now, when we have done a CT myocardial perfusion in stress and rest, to our surprise, we found that all the segments of the LV myocardium show myocardial blood flow, absolute myocardial blood flow more than 100, more than 100. That means there is no ischemic segment only. That is, there is no segment which shows less than 100 myocardial blood flow, 100 ml myocardial blood flow, and the cutoff threshold is 100 ml. So at rest, also we have seen that the lowest is 71 and highest is 90. So we subjected the patient to get a nuclear stress thallium test. So in the nuclear stress thallium test, it is found that the normal myocardial perfusions with adenosine vasodilator stress, no evidence of any ischemia, all the myocardial segments show normal perfusion values. Now, when we go back and look at the CT myocardial perfusion values, we have seen that the amount of LV myocardium or percentage of LV myocardium which is less than 100 ml per minute, that is ischemic threshold, is only 2.35. So this says that the CT myocardial perfusion values are above the threshold of more than 100. That means in spite of showing severe calcific triple vessel disease and CTFFR values in LCX and RCA borderline to low range, the CT myocardial perfusion is showing us that the perfusion is normal. There is no hemodynamical ischemia, which is validated with a stress thallium perfusion study. And this patient has been asked to be on medical management, and patient was not subjected to any invasive procedure. So summing up case 1, chronic diabetic, asymptomatic, CT calcium score 1700 Agatston units, CAG severe calcific triple vessel disease, FFR was positive borderline values in RCA and LCX, but those are false positive because of calcium 1700 Agatston units, false positive, and this dynamic stress MPI, no inducible ischemia, stress nuclear scintigraphy, normal study, no inducible ischemia. There's a good correlation between CT scan and nuclear studies. Follow-up is advanced medical management. Now, case 2, 61-year-old male, diabetes, 25 years, recent onset hypertension, dyslipidemia, TMT mild positive, burning chest pain for 3 months, calcium score is 860 Agatston units. Now, when you do a CT angiogram, you can see that there is triple vessel disease. You can see that LED, mid-LED, there is a tight lesion. Circumflex is borderline lesion in proximal circumflex. In proximal RCA also, there is a moderate stenosis. CTFFR shows that there is moderate stenosis in RCA, LED severe stenosis, and all the FFR values in all 3 vessels are of the ischemic range, saying that there is significant ischemia in all 3 vessels. Now, when we did a CT myocardial perfusion, we found that the myocardial blood flow in LED territory shows that there is one segment shows that significant ischemia. In RCA, 4 segments of significant ischemia, and LCX, 2 segments of significant ischemia. That is less than 100 ml of myocardium per minute, 7 segments total, LED 1, RCA 4, and LCX 2. When we did a stress myocardial perfusion on SPECT study, we could find that the perfusion defect on the SPECT matches with the perfusion defect on the CT myocardial perfusion, matches with it. And when we look at the myocardial blood flow values, we could show that like the SPECT, which is showing a low blood flow, the CT myocardial perfusion also is showing that in RCA territory, 1, 2, 3, 4. 4 of the segments in RCA territory are showing less than 100 ml per 100 ml per minute, stating that these are significant hemodynamic ischemia. And in L6 territory, there are 2 segments that are showing less than 100, 81 and 88. Similarly, same thing is seen on a nuclear stress perfusion study. So there is a very good correlation between the nuclear SPECT study, stress perfusion study, and CT perfusion study. This patient is awaiting revascularization, and on the CT perfusion study, the amount of ischemic myocardium is 49.49% in all 3 territories. That is significant ischemia, and patient is awaiting revascularization procedure. So this is a nuclear medicine SPECT perfusion study, stress perfusion study, which shows that excess stress inducible significant ischemia in large area of LCX extending into infralateral myocardium, but infralateral myocardium, the EF is maintained, LVEF is maintained. So case 2 summary, chronic diabetic, chest pain at severe exertion, calcium score 860 Agatston units, CTCAG severe calcium tuberculosis disease, CTFR simulated ischemia in all three territories, dynamic stress perfusion, ischemia in L6 and R6 territory, and only one segment in LAD territory shows significant ischemia. Nuclear stress perfusion, ischemia in L6 and R6 territories, which corroborates our finding on CT myocardial perfusion. So there's a good correlation between CT perfusion studies and nuclear studies. He's awaiting revascularization. Now, case 3, patient is a diabetic, no other known risk factors, CT calcium score 490 Agatston units, atypical chest pain, TMT mild positive. On CT angiogram, 50-60% stenosis in mid LAD with calcified plaques. CTFFR is 0.84, that is within normal limits. CT angiogram, you can see that there is definitely a borderline stenosis in mid LAD. LCX, there is mild disease. FFR is within normal limits. And when we did a CT myocardial perfusion, we found that all the segments in the LV myocardium show above 100 ml of absolute myocardial blood flow in stress. That means there is no significant ischemia. So, the summary, this patient with chest pain, chronic diabetic, calcific borderline stenosis in mid LAD, we have given that there is no ischemia in LAD territory on dynamic stress myocardial perfusion study. Case 4, 72 male, non-diabetic, hypertension, hyperlipidemia, family history of CAD, TMD mild positive, calcium score 988. You can see here that we have been doing the stress myocardial perfusion in all those who have got high calcium score, and stenosis is equivocal on CT perfusion, on CT angiography, and CTFFR has a role either true positive or false positive. Now, this individual has a moderate to severe calcific stenosis in osteoproximal LAD, then a borderline stenosis in proximal LCX. CTFFR was done and shows that there is significant ischemia 0.72 in LAD, whereas in LCX it is 0.78 and 0.86. So in LCX it is borderline to normal, whereas in LAD it is definitely ischemia. Then we did a stress myocardial perfusion study. We found that there are perfusion defects in the form of purple color areas in the anterior wall and in the septum. And calculation of the ischemic myocardium, LAD 5 segments, LCX or diagonal 2 segments with a cutoff threshold of 100 ml per minute. So the total myocardial percentage which falls under the ischemic threshold is 32%, definitely significant. Cath angio was done. It showed that there is significant stenosis in proximal LAD, like what we have shown in the CT angio. There is moderate to severe stenosis in proximal LCX. Patient underwent stenting procedure and is doing well now. So case 4 summary, non-diabetic, non-hypertensive, TMT mild positive, calcium score 988, CTCAG 2 vessel disease, LAD and LCX, severe calcific proximal LAD stenosis, CTFFR positive in LAD and borderline in LCX, dynamic stress perfusion, 5 out of 7 segments in LAD territory and 2 out of 5 segments in LCX territory show ischemia. CAG was done and underwent PTC and stents to LAD and LCX. Case number 5, 62-year-old male, diabetic, 25 years, no chest pain SOB, TMT mild positive, calcium score 1115 Agatston units. CT angiogram, calcific triple vessel disease, you can see extensive calcium, CTFFR, in spite of the moderate to severe stenosis, FFR values are well maintained, all are above 0.8. CT myocardial perfusion done, all the myocardial segments show myocardial blood flow above 100 ml of threshold 100 ml per 100 ml per minute of myocardial. So that means to say that in spite of showing severe calcific triple vessel disease, that is a false positive severity. CTFFR value are normal. That means CTFFR is giving a normal value here. That is CTFFR is giving a accurate value, and perfusion, CT myocardial perfusion also is accurate, showing that there is no myocardial segment which is less than 100 ml per minute. That means there no hemodynamic stenosis. So patient was put on medical management. So where do we compare FFR and perfusion? FFR is epicardial vessels. Perfusion is microvascular tissue level. FFR is computational flow dynamics. CT perfusion is true pharmacological hyperemia. The clinical sweet spot in intermediate stenosis, 40 to 70% stenosis, and on CCTA without severe calcification, CTFFR is very useful. Whereas with heavy calcification, intermediate stenosis, stents or bypass, you have to do a myocardial perfusion because CTFFR can go wrong in heavily calcified vessels in intermediate stenosis. So that is where CT perfusion helps. And this is what exactly tells us in epicardial arteries, the FFR helps. Whereas for arterioles and capillaries, the CT perfusion helps to tell you about the microvascular dysfunction or epicardial stenosis when there is heavily calcified coronary arteries. The diagnostic performance benchmarks are photon counting CT as on today is the best accuracy because inherent spectral ability. Photon counting CT does not need time attenuation curves or the attenuation values in the myocardium because it measures directly iodine content in the myocardium. It's an inherent spectral CT. So its accuracy is 94%. CT myocardial perfusion accuracy for picking up significant stenosis. Third generation DSCT, 86% accurate. 60 centimeter is 84 to 86% accurate. But with advancements, the CT 60 centimeter and the third generation CT are becoming equally accurate. Only CCT alone is only 68% accurate because of limitation of calcium. When compared to all these accuracy are compared to invasive FFR and invasive CT angiography. Now, how to eliminate the motion artifacts and mitigate the artifacts in dynamic CTI? Cardiac motion, blurring and ghosting, give beta blockers, and use high temperature resolution scanners like third generation or 60 centimeter scanners. Respiratory drift, misalignment across the frames, proper breath holding, because you understand that the CT dynamic myocardial perfusion is a non-breath hold study. It's a shallow breathing study. Coach the patient even before you start the study. Coach the patient not to take high breath hold, not to take deep breaths, and do a very shallow breathing for the 20 seconds. Automatically, you get a good study. All the images what I have shown to you are shallow breathing studies and without any artifact, and all those are done on an AI server. The color-coded images or the calculation of myocardial blood flow, all of them are done on an AI server, so that the AI server will calculate the breath, the respiratory drift. It takes care of beam modeling artifact. It takes care of step share artifact, which occurs on a third generation scanner, but step share artifact does not occur on a 16 centimeter scanner because the table does not move. Only the gantry, it's only single rotation. So there's no table movement. There's no step share artifact on a 16 centimeter. Then what is the accuracy of dynamic CT myocardial perfusion? Sensitivity up to 93%, specificity 83% per vessel. Advantages, you calculate the absolute myocardial blood flow, direct anatomical correlation, but there is some problem of radiation. Now, CTFFR has 90% sensitivity per vessel, 86% specificity. Advantages, no stress, no radiation, extra radiation, no additional scans required, but 25% rejection rate because motion sensitive, garbage in, garbage out. A good quality study will give a good quality FFR. Any motion artifact or any heavy calcium will cause a false positive study. Stress PET perfusion, not available everywhere. It is very rarely available, especially the parameters like myocardial blood flow, quantification of the myocardial blood flow with PET is not available as on today in even the highest centers. So availability is a problem. Extremely high cost, restricted cyclotron access. Now, the stress SPECT MPI is the workhorse, is the widely available modality as on today. That's why we compared with SPECT perfusion and we got very good correlation. Unfortunately, the spatial resolution is less and it does not give you the absolute myocardial blood flow values. So the CT myocardial perfusion as on today, which is going to be very useful, especially when third generation scanners or 16 centimeter scanners are available, is the modality of choice available with us, which can give a direct myocardial blood flow and estimation of significant stenosis. So the core 320 multicenter style tells us that by adding CT myocardial perfusion to CTCA, the accuracy improves by 2.87. The advantages of 16 centimeter are no table movement, so no step share artifacts, reduced follow-up scans. We can do now with recent scanners. I have done most of the studies by using 70 kV, low kV technique. The radiations are very less. Radiation dose is very less. Saves time. And if you can get a good stress perfusion study uh, with proper shallow breathing, in the same study, you can get as a good CT angiogram. You can quantify stenosis. You can quantify absolute myocardial blood flow value also. So by just doing a single stress myocardial perfusion study in a properly tailored study, you can get everything in a single study. That means stenosis quantification and perfusion. So that is the advantage of having a 16 centimeter scanner. Over spec, I told you the resolution is better spatial resolution, 0.5 mm for CT perfusion when compared to 5 to 10 mm for SPECT, less artifacts, absolute values, and the CT myocardial perfusion will give you calcium score, stenosis quantification, FFR, and perfusion values. No other modality can give you at this point of time the absolute myocardial blood flow values. Especially in our country, there are not many places who do the PET perfusion, absolute myocardial blood perfusion, but CT perfusion is being done in at least 5 to 10 centers in India. So if you look at stress CMR, spatial resolution of CT is 0.2 to 0.5, 0.2 for photon counting, 0.5 for non-photon counting. Stress CMR 1.2 to 1.8, SPECT is 4 to 8 above. So the challenges of CT myocardial perfusion are radiation dose can be controlled by tailor-made studies, doing only stress perfusion, asking the patient to do a shallow breath hold, try to get maximum information from a single study. You can reduce the radiation dose to 4 to 5 millisieverts. Then the challenges of adenosine, so on and so forth. But as on today, the CT dynamic perfusion is rapidly evolving and becoming a readily available modality in most of the centers. So future directions, functional cardiac CT is transitioning standard diagnostics from subjective anatomical evaluation to quantitative physiological precision. By combining high-resolution anatomy, computational hemodynamics like FFR, tissue mapping, cardiac CT serves as an ultimate diagnostic engine for patient-centered cardiology. Now, recap, clinical indications for CT myocardial perfusion, intermediate stenosis, 40-69%. You want to show definitively ischemia with objective parameters like getting a absolute myocardial blood flow, do myocardial perfusion, CT myocardial perfusion. Severe coronary calcification, which hinders the FFR and stenosis quantification, like myocardial perfusion is a very good modality. Prior revascularization with stents and bypass, if you suspect ischemia, so do a CT myocardial perfusion. And to differentiate between a coronary microvascular dysfunction and epicardial coronary artery stenosis, CT myocardial perfusion is a very good modality. There are two types of myocardial perfusion. One is static, one is dynamic. Static, both are done using adenosine. Static is only qualitative. It does not give you absolute values. Dynamic, stress and rest. If you do both of them, you get excellent correlation. You can get excellent ratios. That is to calculate the coronary flow reserve to estimate the microvascular dysfunction. If not, only do a dynamic study that is more than adequate to give absolute dynamic flow values. And absolute dynamic flow values, anything less than 100 ml per 100 ml of myocardium per minute is significant ischemia. You calculate in a 17 segment model, calculate the amount of ischemic segments and give the cardiologist the amount of significant ischemia. So in CADRATS 2 reporting, you've got CTFFR and also myocardial perfusion value. So whatever modality you have, you can use, and then you can mention as I plus or I minus. So coronary microvascular dysfunction is again one entity which can be picked up much better on a CT myocardial perfusion, and a global hyperemic myocardial perfusion less than 75 to 100 is usually suggestive, or a stress to rest myocardial flow reserve of less than 1.5 globally is suggestive of microvascular dysfunction. So that is about CT myocardial perfusion, the evolving landscape, lumen to liters, pipe to plants, moving from endocardial stenosis to functional significance. Thank you very much for your attention. I hope all those who have got the high-end CT scanners like DSCT, third generation, and 16 centimeter will start doing CT myocardial perfusion and give your cardiologist the best information about hemodynamic segment stenosis. Thank you very much.